Dr. Riyadh really made my job much easier in terms of the things that I need to cover. I sort of made this, I don't see my slide, okay. I made this more like practical based. I have a couple of cases with some discussions in the middle about really practical life-related issues, practice-related issues. So the first case was a 22-year-old male patient of mine who presented to us several years back on 2014. At that time, he basically presented with a clear-cut ALL case. He has no past medical history and no reason to think he has any familial predisposition for his situation. He had no neurological, he had no extra bone marrow disease, so no CNS disease, no testicular disease. And he did have pre-B ALL. His CD20 was positive, partially positive, but technically with the definitions of what positivity is, it would be called positive in clinical trials. He had no co-expression of any myeloid markers, and his CSF examination was normal. His cytogenetics showed hyperdiploidy with 60 total chromosomes. He had no molecular adverse features found, and his FISH is negative. So there's no hidden MLL or Philadelphia rearrangement out there. And with this hyperdiploidy, as you know, this would confer a better prognosis in this age group, which he would fall under the definition of young adults, adolescents/young adults group. So per that, back in 2014, indeed back since 2008, we have a pediatric-like regimen that we applied in our institution, and we still do. It's a BFM augmented therapy. At that time, we did not include rituximab as standard of care yet, but we did later. So he was started an induction, achieved the CR with MRD negativity, which is expected. He's hyperdiploidy at the end of the day. And he continued his protocol, which goes into consolidation, interim maintenance capesia. I will go through the details, and then delayed intensification. And in maintenance, unfortunately, like many of his age group, he had poor compliance and unfortunately ended up losing follow-up completely. We only saw him for 16 months, and after that he disappeared. He kept disappearing for 2.5 years until came back later. So this is the induction he received. It's a standard induction. We use DEXA in the induction phase. So it's DEXA, Dana, vincristine, and we obviously incorporate asparaginase heavily. Delayed intensification is standard. He would get, as I said, interim maintenance, which is Capezi rather than high-dose methotrexate. And then, so delayed intensification will come later, which is also another round of dexamethasone. So he presented after disappearing for 2.5 years. He presented in 2019 with relapse, basically. He had elevated blast count and clear, frank relapse. His CNS was negative by CNS analysis, but unfortunately no imaging was done, which is wrong. CSF analysis is not sufficient to evaluate CNS status in those patients. So we didn't have CNS imaging at baseline. We don't know what was the status there. Cytogenetics were repeated. He's still hyperdiploidy, so he did not acquire anything new there. And HLA tissue typing was done, and he does have a matched sibling female donor. So the first question here, why did this patient relapse? Well, obviously the first answer is, some people still do relapse. Even the best of the best still do relapse, but that's not the answer that we're looking at here. First of all, at the end of the day, this patient still did receive a pediatric-like protocol, and he's hyperdiploidy. As I said, he's an AYA group. In many pediatric regimens, he would have been included in those regimens anyway, even in North America, where patients in this age group would be mostly treated by adults, but he would have made it. If he was living near City of Hope, for instance, he would have made it to their pediatric regimen easily. So, as you're aware, in North America, they did conduct the first prospective single-arm pediatric-inspired protocol applied by adult population physicians, which was actually presented and subsequently published. It's a trial that utilized such therapy, very similar to the things that this patient received, with the substitution of prednisolone rather than dexamethasone in the induction. But in general, the outline is similar. Induction, consolidation, maintenance, delayed intensification, 1 round. There's no rituximab there. There's no high-dose methotrexate arm. So it's very similar to what he would have received. This study did include patients in the AYA group and adult population. So there were 25% less than 20 years old. Half of the patients were between 20 and 29, which where he was. That therapy, as you know, you're all aware, it was well tolerated by that patient population. Side effect was mainly seen in terms of liver dysfunction. And when compared to a matched population from COG data, it seems that this liver dysfunction was significant. So it's something unique to this patient population. And then as we learned later, it's really related mostly to obesity and liver steatosis. So the question in this patient, would his age would have contributed to the fact that he relapsed? In other words, being 22 years old, is it any worse than being 16 years old or 18 years old? That's an important question. And the reason I quoting this trial, because most likely it does not. And that trial, regardless of which age group we are talking about, they all match pretty well in the outcome. So patients between 60 and 20 did as well as 21 to 29 versus 30 to 39. So in the AYA group, which is anywhere from 16 up to probably up to 40, the age, if you take it as an isolated risk factor, probably doesn't play a major role. I mean, you can see that some of those lines are maybe separating, but the p-value was not significant. Maybe if it's a larger group, it could be significant. We don't know. But in general, that's what it is. So what's wrong with those lines? There's something majorly going wrong with this. This is what's wrong. This is the pediatric data, okay? Pediatric data, which over the years, until we get to the most recent trials of the COG15, for instance, they are talking about a cure rate as much as 90% of their population. And if you give them a hyperdiploidy patient, that patient has a chance of, your chance of curing is 9 out of 10. 9 out of 10. So there is a major gap here between what they would get out of a pediatric regimen in the hands of pediatric hematologist oncologists and what did we get from hands of adult hematologist oncologists who applied a pediatric inspired protocol. There's a major gap which is extending anywhere between 20 to 30%. So, and I'm quoting here a clinical trial, adult clinical trial. The 10403 is a clinical trial. It's not even practice, where practice probably the outcomes could be expected to be worse. So where is that gap coming from? Well, the simple answer is treatments. Treatments in two things. Number one, probably the drugs that are being applied, maybe. So in pediatrics, compared to the 10403, they probably would be using more dexamethasone. They are more generous in their high-dose methotrexate, so they do apply high-dose methotrexate. Maybe these are the two major differences when it comes to therapy. But I think the major effect here, because you're comparing an exactly same therapy, but in hands of adults compared to hands of pediatrics, so the major thing has to do with the intensity of therapy that's being applied. In that trial and in many real-life evidence, ALL patients in the AYA group treated by adult physicians end up getting less dose-intense therapies, especially when it comes to maintenance. So 6-MP, methotrexate dosing, usually doesn't follow guidelines. Those patients are probably non-compliant. And then you have many of them just drop off, like what happened with our patient. This was looked into in pediatric populations. What's the effect of adherence to therapy during maintenance in underserved population in North America? And it seems that underserved populations in North America, they do get less, and this is pediatrics, remember, who theoretically and by all practical reasons, they are more adherent to therapy than adults. This adherence drops gradually over time, and we're talking about intended dose intensity of 6-MP by 90%. That's what their target is. So people who got less than 90% of the intended dose intensity had significantly higher risk of relapse, 90%. So just run in your head all your adult patients on maintenance who receive pediatric protocol and run what are the guidelines of maintenance and see how many of them even reached 90%, not to mention the non-adherence by patients. So first of all, definitely the fact that he dropped off, he never showed up after 16 months, and probably he was not compliant before that, and probably also our mistake of probably not following regularly with our patients, calling them back, having good social worker support, and so forth and so on. So that's the major factor in his relapse. But there are other factors that could have played a role as well. Other thing is that regimen, as I told you, when we applied it, we had Capezi MTX during that time in 2014. Well, since then, there is an evidence, mainly from the ALL 0232, which is a pediatric COG trial, which one of the randomization in that trial was high-dose methotrexate versus Capezi, and it included patients with pre-B as well as T-cell. In that trial, to make a long story short, patients who have slow early responders in pediatrics, so SERs, slow early responders, which are a higher risk population in pediatric, would have benefited from receiving high-dose methotrexate. And I'm talking about pre-B ALL patients here, okay? So I don't know if he's SER. We don't check for SER in adults, but he's probably higher risk only because in this age group compared to ages 1 to 10 in pediatrics would be automatically higher risk group. So probably he would have benefited from high-dose methotrexate as well. So that's reason number 2. Reason number 3 is rituximab. Well, as we know from adults in hyper-CVAD, for instance, there was never a randomized clinical trial in hyper-CVAD, but their historical data of hyper-CVAD pre-rituximab versus hyper-CVAD post-rituximab, it seems that after they applied rituximab in therapy, they did achieve better progression-free survival and better overall survival. So this was retrospective. Well, it wasn't until the French did a randomized clinical trial in adults that implemented rituximab 10 doses dispersed from induction to consolidation. And it seems that, yes, rituximab does increase the cure rate, not too much, less than 10%, but it's significant. So it does add something to those patient population. Well, as I said, we didn't apply rituximab with our BFM protocol. We did recently, since 2017, I think. So I just looked at this a couple of days ago. So the one on the left was what was reported by Dr. Salim before. There are some patients missing in the middle, but the point is that pre-rituximab, we did achieve MRD negativity in 77.2% of the population. Post-rituximab, our MRD negativity rate is 88%. I don't know if that pans out. We only have 17 patients so far treated with RBFM, but we'll wait. I believe it's probably working. The good thing is that we didn't have any induction death with rituximab so far. And when I say induction, I mean induction and consolidation. So no increased toxicity in the initial phase, probably with increased MRD negativity and remissions. So probably those are the 3 factors that would have explained his relapse. So he relapsed. I would still consider it a low-risk relapse. He's still hyperdeployed. He didn't receive full therapy. So that's why we re-induced him with our hyper-CVAD. Okay? He received block 1 and block 2. And post-cycle 2, he was still MRD positive. His MRD is 0.2. Okay. Well, during cycle 2, he complained to one of his treating physicians that his visual fields doesn't look right. And he said this was actually from the beginning. And that's what I said, emphasizing that imaging is important, not only CSF analysis. Imaging was done in his case. CSF was negative, and imaging was done. This was during cycle 2 of our hyper-CVAD. And he did have retinal detachment, which doesn't look related to leukemia, mostly related to bleeding, but he did have optic nerve infiltration in the periocular area. So he probably had infiltration. Whether or not it was present from the beginning, its progression, I have to believe it probably was present from the beginning of relapse. So this is him. This is cycle 2 of our hyper-CVAD. He's in remission. He's MRD positive, and he still have this thing in the eye. So what is it the best to do? You know, you have several options here. You can say, well, the guy is ready. Take him directly to transplant. You could say, well, he's not ready. We need to give him more salvage. Give him FLAG-IDA. You could say, let me give him only radiation to the eye and control that, and then take him to transplant. And you can say, this MRD level is not acceptable to me. This eye findings are not acceptable, so why not to give him radiation to the eye and try to eliminate the MRD status, which he did. No need to talk about MRD outcome before transplant. Dr. Riyad already mentioned that. Patients who go to MRD, who are MRD positive and go to transplant, their outcome is significantly worse. It's not within the acceptable range. It's significantly worse. So that's not an option. And I think we need to eliminate MRD in his case. This is not acceptable as well, because if he has extramedullary disease, blinatumomab would not work very good for that. You could say this is CNS disease, blina is risky. Well, yeah, but it could be given still. He did get it. He did not have any CNS toxicity. And you need to control both. So he got radiation to the orbit area, and he received 1 cycle of blinatumomab, and he achieved MRD negativity after 1 cycle of blinatumomab. So, and then he was taken to transplant. Actually, today is day 10 of post-Cy TBI preparative regimen. Cycle 2 is a 16-year-old female who has no past medical history, no family history. She presented with ALL, basically. On flow cytometry, she's CD20 negative, okay? No myeloid co-expression. She's cytogenetics normal, BCR-ABL negative, FISH negative, bone marrow typical. So this is a new case. So she would be treated with our BFM protocol, which she received. So it's BFM induction plus rituximab. This is our protocol: dexa, vincristine, peg asparaginase, daunorubicin, as well as rituximab. So you would ask why to give her rituximab and she's CD20 negative. We don't know. We are basing this on some lab-based data. So there was a publication back in 2008 about CD20 upregulation with the effect of steroids. Those guys, what they did, they collected blood samples on patients treated with induction, pre-prednisone, not dexamethasone, prednisone. Probably dexa would be even better in that regard. So pre and post, so at end of induction, and they've seen that CD20 expression goes in peripheral blood and bone marrow, so and just to eliminate the issue of normal lymphocytes. It seems that CD20 expression does go up, and the amount of patients who are CD20 negative towards the end of induction, this is MRD positive patients, by the way, obviously, because otherwise, how would you even check for CD20 expression? And this CD20 upregulation is not only, is not clinically insignificant, it's actually clinically significant, because they did in vitro studies with rituximab for those cells, and it seems that those cells are still sensitive to rituximab effect. So those cells were CD20 negative, got CD20 upregulated, and are sensitive to rituximab effect. So based on this, we incorporated rituximab in our induction. Dr. Salim just alerted me yesterday that in ASH there's MRC trial that looks into specifically on this. Yes, so If you're going to ASH, look at this. So this patient received this induction. She had neutropenic fever, coagulopathy, grade 3 anaphylaxis, was managed per our protocol, detailed guidelines of what to do. She was switched to Erwinia and coagulopathy. We don't correct if they don't bleed. End of induction, her bone marrow showed 4% blasts, 4% blast. So by definition, it's M1, which is less than 5%. Per our protocol for those patients, we say if they are M2, they go to consolidation directly. If they're M1, which she is, let's concentrate on that, but she's M1 MRD positive, she will get consolidation regardless on day 36, so we don't wait for those for recovery. So she went to consolidation, and the reason behind that, you would say 4% is too much at end of induction. Well, it's not, because like Dr. Riyad said, MRD does pick up later. MRD at week 4 or 5 would be too early to check, because from the German data, we know that by end of induction 1 to induction 2, you gain another 10% of MRD negativity. By end of consolidation, you bump up another 15 to 20%. So you're still gaining by time. So it's too early to take a decision at end of induction. So she got the 2 blocks of consolidation. That would have brought her to week 13 or 14. And that's pretty much it. You're stretching it right now. So week 14 for pre-B is pretty much on the limit. You don't want to wait any longer than that. Now in T-cell, it's different. You probably could wait longer than that, but in pre-B, definitely not. Week 14, 15 is probably the limit that we're talking about. So at end of consolidation, her MRD was still 0.01, which is 10 to the minus 3, 2, which is significant. Okay, that's not acceptable. Indeed, in our protocol, any MRD, and we're checking only flow. So any MRD by flow at that point would be unacceptable. We need to do something about it. And we did include for those patients in the protocol blinatumomab. We give up to 3 cycles of blinatumomab, and we say until MRD negativity. So if they are MRD negative after cycle 1, they stop, and so forth. So she did get 2 cycles of blinatumomab, and she's MRD negative after cycle 1. Okay. She didn't have a full match-related donor, and she refused to go to haplo. We sat down with her and family, obviously, and she continued. This was old slide. She's in maintenance right now, indeed. So, you know, the issue of Dr. Riyad alluded to this already. 2 minutes. 2 minutes, okay. The issue of the role of blinatumomab and allogeneic bone marrow transplant is pretty controversial. We really don't know 100%. Most people would still send those patients to transplant, but the picture could be a little mixed. You know, from the trial that was published, patients there was no difference in the overall survival and recurrence-free survival for patients with allogeneic versus who went allogeneic and did not go to allogeneic, especially patients who achieved MRD negativity with 1 cycle of, if they received blina for MRD positivity only, and they achieved MRD negativity with 1 cycle of blina. There was a publication in ASCO, this 2018, which looked at a bunch of patients post-blina who underwent allogeneic bone marrow transplantation, either because of MRD positivity only, they got blina, or because of relapsed disease. And to make a long story short, from that trial, patients who benefited the most, who received blina for MRD positivity, obviously, and who were younger, so younger population, and because probably of toxicity, obviously. And the third is that they achieved MRD negativity quickly. But anyway, those patients, they would have done good anyway, because we know that from the original blinatumomab trial. So if those patients achieved MRD negativity with 1 cycle of blina, their outcome would have been good anyway. And it's hard, even with the slide that Dr. Riyad shown, the difference, yes, there's decrease in the relapse rate with blinatumomab by almost 28%, but if you add the toxicity, death, it's almost 25%. So, and that included everybody. Okay, and so if you want to ask me what's the one criteria that may help you to say, I want to treat this patient with chemo alone, is probably early MRD achievement. So one cycle of Blina, MRD negative, I don't know what's the benefit there. This is the last I checked, we have probably treated around 25 patients with blinatumomab, different patients between adult and pediatric. Our patients who got treated with Blina for MRD, okay, MRD, the MRD negativity rate at our center was 85%. 85%. So out of 10 patients treated for that purpose, 8 of them are alive without relapse. Okay. Some of them underwent transplant, some of them didn't. It's a mixture. But that's it. So just two things to keep in mind. Maybe we will get some updates in the next ASH. You know, all what I've shown you is what we do, which is a BFM protocol. Some people don't apply BFM protocol, but there is evidence for blinatumomab used in the setting of hyper-CVAD. Again, it's a prospective single-arm study, like many MD Anderson studies are. They give 4 cycles of hyper-CVAD, followed by blinatumomab for another 4 cycles. And they did, in that trial, which was presented last ASH, their CR rate is pretty high. MRD negativity is above 90%. So that's for younger population. You probably all heard the presentations as well for older population of applying mini hyper-CVAD, inotuzumab plus blinatumomab, also MD Anderson data. And that trial also, which is mini hyper-CVAD inotuzumab followed by blinatumomab for, they did achieve MRD negativity of 78%. And this is their CR and overall survival data for an older population, which looks pretty significant. You know, if you look at it 5 years down the road, if you're talking about 50% of those patients still alive without disease, it's pretty significant. And that's it. I would stop here. Thank you very much.
Dr. Ahmed, I think we can take questions now.
To the podium, just we'll ask the audience if there is any questions. So maybe I will start with the question. Do you think the incorporation of blinatumomab upfront with the use of what sort of chemotherapy that you are using, either pediatric-based regimen or versus the adult type of regimen, would be the way to go in the long term to reduce, to achieve more deeper remission, which is be translated to longer term survival?
Out on the intensity of chemotherapy in adults by using pediatric protocols. We still has some room, like Dr. Absi said, with compliance, improving compliance of the patients. But we're almost maxed out on the chemotherapy. We have to use alternate mechanism to deepen the remissions by using immunotherapies, whether it is CAR T-cell, inotuzumab, or Blina. And probably these will improve the rates of MRD negativity and the survival. The problem is you'll have to look for different types of toxicity when combining these immunotherapies with the chemo. Probably it'll be a block combination where you get chemo at one point, immuno, not all together like MD Anderson is doing. The other problem is like with Blina, up until now, we have to admit patients and they will stay in the hospital. So logistically, it's a little bit challenging, but definitely this is the future. And the cost, of course, still the cost of immunotherapy is very, very expensive.
Yeah, I mean, I agree. I wouldn't add much. I think, so the answer, the short answer is yes. The problem is how. And like many other things in ALL, the problem is that you will never have a randomized clinical trial. All what's going to happen is practice-changing kind of trials where as you will see on, time coming, people will apply the hyper-CVAD regimen if they do have the financial resources, because that's the easiest thing to do. 4 cycles hyper-CVAD, 4 cycles of blinatumomab, it's easy to apply. Whether or not this is good, it's better to apply a pediatric regimen, put it in the middle. I guess probably we won't have those answers until we have more data from pediatric trials, which do better randomized clinical trials, and understand the toxicities better, and how decisions like simply what's the role of allogeneic in CR1 in those patients. We don't know those answers yet for 100% certainty. But the short answer is yes, for sure they are moving towards the upfront therapy. And that's the best we can, from our data, that we learned, and I think everybody who used the medication learned, if you use it later, it doesn't work that well. The longer you wait until you use it, so you use it in first relapse, it's better. If you wait to see if a second relapse or third relapse, the chances of it working is probably very minimal. But on the other hand, if you use it in MRD setting, it's working in 8 out of 10 patients. So that's pretty significant activity.
I'm doing right now a meta-analysis to look for patients, adult patients who receive pediatric-inspired protocols, randomized, non-randomized studies, to see which patients benefit from going to allogenic transplant. I'm still in the middle phase of doing the meta-analysis, but the problem is the studies are very heterogeneous, and I think we may come up with some conclusion from the meta-analysis, but still heterogeneity will be a problem. And we tried to look at subgroups of modern high-risk groups, old high-risk groups, MRD, whom could benefit of transplant. Hopefully that will provide some answers. I have a question for Ali. I don't know if contrasting adult data with the pediatric data for the use of blina for MRD positive cases. Do you use blina for MRD in pediatrics before going, or what do you do? Does that change your protocols?
Thank you. We are very similar. Usually if we get an MRD positive end of induction, we, especially low positivity, we move to the consolidation one. And if you have a positive MRD at end of consolidation, then that will be the time of discussion of using blina. So if we have it available, and then used as a bridge to bone marrow transplant. So that is how a lot of people doing it. Currently, there is an ongoing study from the Children Oncology Group using blina for those category of patients who had actually a positive MRD, not only by flow, but actually by more molecular testing. So if you have blina positivity post-consolidation, that is the time. The other study, which is interesting, they're using now, they're upfront using CAR therapy for those who had positive MRD post-consolidation, which has never been used. Those are for upfront. The study is, I didn't think yet started, but it's again one of the COG study. I just want to make a note here that is for the patient who 14, 15, 16. We are still struggling with them, even in the children group. And if you look at the subset analysis for those group, we are not really talking about 90% or 80%. Those are what we label them initially as a slow early responder, or nowadays we call them very high risk VHR. You are looking at, probably 50, 60%, which is not as far from the adult one. So those are a group that we try to intensify everything so they get the higher risk. Recently, the COG tried to intensify the current BFM backbone by using CLO, etoposide, and cyclophosphamide, but that actually was more toxicity, so they stopped that things. So it's still not an easy group to treat, and probably the 90% is reflective of more of the younger one. The older one is hard. In the recent 0232, age was a factor. Like above 13 was actually one of the very high risk age group as compared to the favorable group, the younger one.